this webinar this afternoon. It's my pleasure to host you this afternoon, this interesting webinar where we'll be discussing ethical considerations, ethical and medical legal issues during this COVID-19 response period. My name is Dr. Agnes Karingo Karume from Kenyatta National Hospital. I'm a member of the ethics committee in the hospital and will be taking you through this session. With me, I have a robust team to take us through these discussions and this conversation. You will be meeting them in a few and they'll be speaking to you. We have Dr. Lydia Okutoi, who is a Director Healthcare Quality, and she will introduce the other members and ask them to introduce themselves as we start. For the CPD points, if you have any queries concerning CPD or you'd like to receive CPD points, kindly email knhcpd@gmail.com and cpdfarmer@gmail.com. You are very welcome. Be free to participate. We'll have your questions you can type in your questions and we'll be able to respond to them. And let's have this conversation. Really, what are the ethical issues that you are facing during this period? Thank you very much. We have Dr. Okutoi speak to us. Thank you.
Thank you, Agnes. Good afternoon, colleagues. Once again, we are glad that we're here again to discuss ethical consideration during this pandemic and generally just an overview of what this is. This Thursday is a great day because in the morning, I think there was almost a 2-hour, I think 3-hour meeting by the Bioethics Society of Kenya, and some of you, I know you attended, on ethics and use of data and how that it's falling in the time of COVID. And so we now come talking about clinical ethics. So as mentioned, my name is Lydia. I head the Secretariat for Hospital Ethics Committee. Our chair is Dr. Wambugu, renal physician. Just a little background that this is a group that is less than 2 years old. I think we're almost clocking a year. A committee in Kenyatta composed of about 23 people and having over 35 champions. And our role is to promote ethical clinical practices, review, and give guidance on ethical issues arising from clinical care amongst us. As we know that occasionally the professionals and the patients may disagree about values, and the choices that they have to make at times may challenge their values during care. And so that brings ethical dilemmas that each group coming here has a right and it needs to be considered, and yet there is what is good and right to do. In essence, ethics considers matters honesty, fairness, equity, respect very highly, inclusiveness. So it is the moral and the right thing to do. So as our committee, our role has been clearly cut, but we are still in the process of creating a demand for a systematic approach to these matters across the institutions. And not many hospitals have a hospital ethics committee. And so we are learning the ropes as we get mentorship from the various groups. We've had mentorship from UNESCO group, also from the group from the Bioethics Society. I think the professor from Egerton came and talked to us, and the Cambry group led by Professor Abukusi also have done as good by giving us opportunity for mentorship. So that is just a background so that those who are listening from various institutions who may want this to happen in the institution, having a systematic approach towards ethical issues and having a structure that supports it, can also learn from the ropes that we have walked. And so today, without much further ado, allow us to dive into the main subjects. Ethics has challenged the fabric of how we do what we usually do. And so the strains have led to conversations. And that is what we intend to dive in today. So Dr. Karingu, you're welcome to proceed. So we will have a number of panelists, presenters, but they'll be very short. Then we will open up for further discussion. So once again, thank you. Dr. Karingu, you're welcome.
Thank you very much, Dr. Toy. And just as I begin, I'd like to introduce one panelist who's our legal expert, even as we begin, to have just a short introduction of what he does and his role, and we'll just carry on from there. His name is Dr. Fleming Lumumba. You can give us just a short introduction, then we dive into the topic right away. Thank you.
Good afternoon, everyone. My name is Lumumba Fleming. I'm a legal officer, Kenyatta National Hospital, and a member of the Hospital Ethics Committee. It's a fairly new role for us, and it's been exciting. So I'm here to augment the discussion for today. Thank you.
Thank you very much. See, we have a reverse team. We have our legal expert. We have Dr. Juanita Odrot, who will also be giving a short presentation after this. And thank you very much. You're welcome to give your questions to type in your questions, and we'll be able to get back to you. So as we begin, what are these ethical considerations? What are the ethical things that come up during this period as we are responding to this pandemic? And importance of clinical ethics. Why is it important to have this conversation on clinical ethics? And really, ethics gives us a moral compass, a moral compass for decision making. During this time, even in a public health pandemic, we have a lot of decisions that need to be made. We've had decisions being made from the national level, at institution levels, at even individual levels, and at times we find ourselves at crossroads in regards on how to move forward. And ethics comes in to provide a way forward, or to give us a backup on what we need to do when we are faced with either ethical problems or ethical dilemmas. And that's why we are having this conversation, and we're saying that it's important to have clinical ethics as a background in making clinical decisions during this period. It promotes even also the patient-centered, the person-centered care, both from the patient side and from the staff side. And so what are the basic principles that we base our decisions on, or clinical ethics? We have four main principles. We have autonomy, we have beneficence, we have non-maleficence, and we have justice. And as Dr. Okutoi has put forward to us, that as Kenyatta, we have the Hospital Ethics Committee that is beginning its operations and implementation. And we have these four basic principles that we rely on. Autonomy autonomy is giving someone the autonomy, or giving someone the right to have their own decision making, to make their own decisions. And here we're saying that we'll acknowledge people's right to make choices for themselves based on their own values and beliefs. We'll see how this autonomy plays out during this COVID-19 period, whereby are we able to make our own decisions? Are we guided by the decisions that are being made from the national level, policies that we have? And we will see how that comes in. Beneficence, I will do and promote good at all times, which is very important, that in everything that we do, in every decision that we make during this period, it's for the good, either for the individual good, for the collective good, but we do it for the good of, or to promote good at all times. Non-maleficence, I will not inflict evil or harm. And justice, treating others equally and fairly. And so how do we make this ethical decision? How do we come to a conclusion when we're at a dilemma? And this one is just a short form of how we go about this. We identify the issue. What is the issue at hand? Because without knowledge or without identification, we will not be able to make progress. So is it an ethical problem that I have? Is it an ethical dilemma that I have? And the difference is in a problem, we have problems we face on a day-to-day basis. And we have many problems, and we'll even have some cases that we will discuss. But how do we move forward and have a decision? How do we identify the options that are available? So identifying the problem or the dilemma. Dilemma is whereby you don't have you are in the word fails me for now, but you don't have an option, or you don't have a way out. No matter what you do, you don't have a way out of it, and you don't really have options. So how do you identify these issues? Study the facts. What are the facts on the ground? Select reasonable options, or employ all the options that are available to you to come to a conclusion. Understand the values and preferences, the quality of life. So understand the surroundings of the problems that you have, evaluate them, and sustain and have a sustainable plan that you can review. So some of the ethical considerations that we'll be discussing are, during this period, the resources that we have. Do we have effective use of resources? Both physical, financial, human resource, and especially human resource that is important. How are we using this? Information use, information privacy and confidentiality. We have positive results, we have negative results. How far can we go in giving this feedback to the person involved, to the immediate person, and who else are we telling this information to? Are we maintaining their confidentiality? Autonomy in decision making. Are we able to make our own decisions? Are the patients able to make their own decision in regards to the care that they want? If they need isolation in a particular place, are they able to make that decision on themselves? And how do we enable this decision making process during this time? Individual preferences, needs versus collective needs. We've had from other areas saying, no, we won't wear this mask because why am I wearing the surgical mask? It's against my rights. I don't prefer to wear this particular kind of, and really, what are the issues? What are the individual preferences, and how do we connect these two versus the collective needs? What are some of the rights that come into place? What are the legal perspectives in this? And so this is what we'll be looking into and having a short candid discussions on. And at this point, I'll invite Dr. Juanita Oduor, who will take us through our next just short presentation in some of the cases, and we'll delve into the discussion. Dr. Juanita.
Good afternoon, everyone. I'm just going to do a short presentation highlighting what we come across in the hospitals. It doesn't cover everything, but I had a couple of short cases which can highlight a few of the things that Dr. Karima had talked about. So these are a few ethical issues managing COVID-19 patients. So the first case, we have an adult patient that comes in, has respiratory symptoms, so the coughing, they have problems breathing, they may have a fever, things like that. They're attended to at the accidents and emergency, and a COVID-19 test is advised due to the symptoms that this patient has come in with. This patient declines to have the test done. That is one case. Another case is an adult patient comes to the emergency department with respiratory symptoms. Patient is attended to and stabilized according to the symptoms. COVID-19 test is performed. The patient is sent to isolation ward to wait for the results. The results of the COVID test turn out to be positive. Now this patient is to be moved to a COVID positive facility, in this case to Mbagathi IDU, the Kenyatta section, to be managed there. The patient declines to be moved to Mbagathi IDU. So these are a couple of the issues that we've come across, and that in itself brings up ethical issues because, as Dr. Karimo had talked about, ethics is personal, but in a pandemic, it involves the public. So questions which are of concern to ethics, whether it's to the patient or whether it's to the healthcare worker, some of them are these. Number one, why won't the patient get the test done? What value or meaning does this patient hold in regards to this test or the results? What is the value or meaning does the healthcare worker hold in regards to the tests and the results? And why doesn't the patient want to go into isolation? Is it the facility? Is it the healthcare workers? Is it society's perception, understanding of what this pandemic is? Is it the religious beliefs, or is it family and social beliefs? So in this, we have some ethical issues which arise. So I got this reference from the Hastings Center in concern to COVID-19. When we have a pandemic, there are also non-pharmaceutical interventions, which I'll call the NPIs. These are things like isolation, quarantine, school closures, social distancing, which have been considered in this pandemic. Most countries have put this into place, including us. And then when what are they called? When these interventions are being put into place, then we must make sure that we meet the harm principle, which is about actions of individuals should only be limited to prevent harm to other individuals. So in the case of the masks, you know, like Dr. Karingo talked about people refusing to wear masks, or they don't want to go to a different facility, or they don't want to do the test for whatever reason. It applies to this individual who feels that their rights are being intervened on, but it's to prevent harm to other individuals. And in COVID-19, it's to prevent the spread and possible imminent death of some patients. So some of these NPIs is the most beneficial and least friction. When you introduce a policy which is beneficial to these people, and it provides the least friction, whereby most people think about their rights being intervened on, or think about their social movement or their religious rights, things like that. If you have them voluntary with respect and rely on individual autonomy, you avoid using police powers. This is not always the case. In some cases, we have to put in a law to enforce some of these non-pharmaceutical interventions. But if you have a transparent application of the NPIs with accountability and protection of civil liberties, you're much more likely to have the communities have a robust public health system. Much more likely if the communities have a robust public health system in place before the pandemic strikes. So transparency, accountability, and protection, those three things which come into our policy and our lawmakers. So this is the situation we've come into with the non-pharmaceutical interventions. Because now if you go into the hospital with what we've learned from this pandemic, we know certain things have worked, certain things haven't worked. We're still learning. So there's some confusion, there's a lot of unknowns, and so it brings a lot of anxiety to a lot of people. So if you look at both cases, the patient would need to understand the condition, how it affects them or how it affects others. In this regards is to what is known about the disease, how it will affect their life, in the sense that if they're admitted, I will receive this kind of care. I will be isolated from other patients, from society, from family members. I will not be able to go on with my daily activities of life. And while they're in treatment, and when they recover from this disease, or if they don't recover from this disease, what are the possible outcomes? Will it become a situation where you're isolated at home, or you're isolated in the hospital, whereby you cannot see your family as you usually do? Or when you come out of the hospital having a negative result, how will society receive you? How will the general public receive you? Because there's a lot of issues going on in society when a lot of things are unknown. Counseling should be done before and after the test. It reinforces some of these things, some of their concerns, some of their questions, in the same way that we do for HIV. In this way, the patient will understand the implications of having a positive or a negative result, and how to kind of protect themselves and how to protect others when it comes to this pandemic. So, with a bit of the ethical and legal issues in this pandemic, I will refer to Fleming to help me out here a little bit. So if a patient that tests positive for a particular disease in a pandemic, this is overridden by public safety. In the case for refusal to be admitted, like in case 2, the patient's concerns and fears should be addressed, but if refusal to be admitted, the refusal to be admitted should not be considered. So this is the benefits outweighing the risks of having a positive patient out there, possibly infecting quite a few people, or being isolated and getting treated or overcoming this virus and becoming better to rejoin society. So to stop
Dr. Yonita, we are not able to get you clearly.
Is necessary. With high suspicion, this is right. There's no legal ramification. Can you hear me better?
Dr. Yonita?
Yes. Can you hear me?
Okay. Now we can hear you.
Now you can?
Yes.
Okay. So should I continue from here or should I go back?
Go back like from the beginning of that.
Go back a little bit from the beginning of the slide.
From the beginning?
The next one.
This one or that one?
Next one.
That one? Hello? Can you hear me? Hello, can you hear me?
Yes, Juanita, we can hear you.
Okay. So I'll continue. I'll start again with in regards to ethical and legal issues in a pandemic. So a patient that tests positive for a particular disease in a pandemic is overridden by public safety. In the case of a refusal to be admitted, the patient concerns and fears should be addressed, but if the refusal to be admitted should not be considered. So refusal to be admitted is overridden by public safety in that regard. If they refuse to be tested, that's when now we have a challenge, because so far we don't have any legal ramifications for refusing to be tested. However, considering the risk to other patients, like the inpatients and the healthcare workers, it is very strongly recommended. When you talk about stigmatization, we have social stigma, which is a disapproval of and discrimination against a person based on perceivable social characteristics that serve to distinguish them from other members of society. In Kenya today, there's still a stigma associated with testing and having COVID-19 positive test. This stigma is underlying in case 2, whereby someone will refuse to be admitted to a ward because of their feelings about what is happening on that ward. There's a belief out there in society being admitted to such wards means that the care stops, there's no equipment, there's no medication, or the staff just does not provide care. This belief of being admitted to the ward is almost always a death sentence for the patients, or even sometimes some staff are considered contaminated. Even patients who come out negative are sometimes considered contaminated. This is a factor when making a decision whether someone should be admitted or not admitted on the patient's point of view. So these are some of the issues that we are coming across when we're tackling suspect and COVID-19 patients. I feel that maybe we should look at these cases a little bit, and then if there are any questions or if you want us to move on to the next case, then we can discuss it on the ethical and legal issues. And I'm hoping Mr. Fleming will join us in highlighting for us and clearing up for us some of these legal issues. So in case one, if somebody refuses to have the test done, has anyone come across that? Do they have any cases or examples that pertain to this where it raises moral issues? I'm opening up the floor to anyone who does.
Thank you. Thank you very much, Dr. Yonita. In view of the managing the time and of the number of questions I'm seeing, we might not be able to go live as such, but we'll have that discussion. I encourage our participants to put their questions in the question and answer, to type in their question in the question and answer to all the panelists, and you'll be able to see it and discuss it live. So for now, as we discuss this case, when they coming down, I'll hand over to Dr. Okutoi.
Okay, thank you.
Thank you, Dr. Juanita. Indeed, after the legal colleague, when Fleming presents, we will let her go to those cases so that we're able to just manage the time. So as to give a short case, sorry that I'm not sharing the slide share. We have begun our ethics consultation at the hospital, and just to share without really having disclosure of the names in terms of ensuring that we have confidentiality. So a case of a minor who's admitted to the institution with a blood condition, and during our care, we determined that it is could be blood cancer, acute myeloid leukemia. And so we need to confirm what the child has, and then to begin the appropriate care. So in further discussion on the next step, it is confirmed, the mother voices their concern that, yes, you've mentioned that it could be cancer and it's of the blood. And everybody that I've ever known who started treatment for cancer in the hospital did not go home. They all died. And so I'm not willing for my son to start the treatment, leave alone doing this test. The test happens to be an invasive test, not too invasive, a bone marrow test. So it means that I have to, the mother will have to consent for some needles to be placed somewhere to pick some samples, and she's not willing, consenting for that. So this is apart from the COVID that you're discussing, there are real ethical issues that we have. And so for us to manage this patient who is a minor and the parents are not willing, so how will we proceed with that? I think after the legal colleague has given his perspective, then Juanita will lead in answering the questions from the case 1 and case 2, and the one presented of the minor is case 3, because these are a real issue. So as much as we have COVID with us, the other conditions continue being there. The other ethical dilemmas that come in provision of care continue to happen within the institution. So we will turn over to Mr. Fleming, and then we will now be addressing questions, not only questions, but then also your feedback. So there is the case 1 for testing. We ask that you chat on the chat box on what approach or what ethical issues are arising from refusal of tests. And then also the next one of refusal of admission. And then there is this also refusal of continuing of care because of fear of the child dying. So we'll proceed to Fleming to shed some light from the legal aspect, and then also to share examples of how during the COVID pandemic, generally within the institution and beyond, how we've had the strain between the various rights between the population, the state, and the people and the patients. So Fleming, You're welcome. And we will continue at the background to take the comments. And you, Anita, will direct all the comments for the cases towards you. Thereafter, I think then we will allow a few people to share their comments live, but the rest will be grouped so that we do not repeat what has already been answered. Thank you very much.
Thank you, Dr. Okutoi and Dr. Anita. I don't have any presentation to project. However, allow me to highlight a few issues regarding legal aspects of COVID-19 pandemic management that go to the core of the discussion today. Allow me to mention that the interaction between law and public health, especially regarding the pandemic as at now, grants the state fairly broad powers. And apart from that, it also places the duty on the state and by extension, the hospitals that are run by the state and perhaps maybe the private individuals to assure the conditions of the people are healthy. And apart from that, it also allows the state to limit the powers or to constrain the enjoyment of certain rights, which are key in terms of in terms of ethical consideration, like autonomy, privacy, liberty, and so on. And that's why you have seen, or courtesy of the health expert, we have been having the isolation, the quarantine, the curfews, and so on. Now, regarding the topic of discussion today, together with the examples that have been given, allow me to narrow down to specifically two issues, which in my view, hits the nail on the head of the subject matter today. For me, which relates to the safety to the patient and the practitioners. And together with that, I'll just talk a little more about the issue of confidentiality, because it encompasses most of the issues that have been discussed so far. Now, looking at the safety duties to patient and the practitioners, majorly it relates to the duty of care, for which all the principles that were listed at the introductory stages apply, whether be it those duties that are owed by practitioners to their patients, which include the COVID-19 patients and even those that are undergoing regular treatment as of today, or even those that are owed by your employers, my employers, the hospital, and the managers to their staffs. All these particular things or duties are predicated on the doctrine of reasonableness. So we may be asking ourselves, what is reasonable in pandemics or at such time? What is it really that may remove us from the ambit of the law or from being in conflict with the law, especially when we interact with COVID-19 patients, or even those particular patients who've shown signs or refusal of treatment and things like that. The reasonableness is influenced by so many things, which touches on the availability of the resources and including principally the staff and the equipment. You are aware, going by the trend of the statistics that we receive daily, numbers keep rising, and we are bound to be discussing these things at some point. And that's why you see counties are moving so fast in terms of updating their capacity, in terms of bed, in terms of equipment, in terms of staff, so that at least we may have the reasonable resources to combat the pandemic, and which would ultimately lead to what is reasonable in complying with the legal duty of care at such particular time, because there is access, there's that right of access to health and treatment for patients, not only to the doctors, but also to the public at large, because we are looking at the duty of care that is owed by the practitioner to the patient, and also there is a corresponding duty that the employer owes to you as a staff, and all those particular circumstances. So regrettably, at some point, I've been following keenly the situation that happened in Italy, Lombardy, for example, and the things that may lead to ethical consideration, where a doctor may fear the consequences of his or her action. And going by the numbers, ultimately, we will be asking ourselves question at some point. Can you hear me? Can you hear me?
Yeah. Yes, we can hear you.
Okay. Regrettably, at some point, going by the numbers, we may be called upon to introduce other methods of triage other than the ones that we are used to at some point in time, relating to the ultimate choice between who is to be given the continued chance to live and who is not. So in this particular perspective, under the duty of care, allow me to say that there is nothing unlawful at this particular stage to make that particular choice, provided that the decision is made on the basis of reasonable assessment of the treatment facilities, which are which which are likely to be available to the patients. So in any event, even if an error is made or harm ensues as a result of that particular decision, the law imposes liability only if there is a sufficient causal link between the mistake and the untoward result, or the unintended consequence. So what I'm trying to say at this point in time, that we should be prepared in future, going by the numbers, that as practitioners, you would be called upon to determine who really needs that particular equipment, going by the scarcity of the resources, going by the scarcity of the facility at this point in time. So that you should not feel guilty when you develop other particular modalities of conducting such particular triage. And in terms of the issue of confidentiality, I know at this particular point, and more so over and above other reasons that perhaps maybe parties are attending this particular webinar, is we are looking for that particular reassurance as practitioners that whether we experience perhaps maybe a particular case in COVID pandemic where somebody refuses treatment, or where in our own daily interaction with the patient, we have reasonable suspicion that such a patient present a danger of infecting others, and perhaps maybe distancing or shielding the particular patient from the rest may be impracticable if we should really divulge such particular information to third parties, so that they may be aware of the danger that that pertains to them from this particular individual who has refused particular treatment. So in that regard, the general rule then is that it is then legally permissible to share such particular information, so far as it appears necessary to reduce or eliminate the danger that results from the pandemic, or the danger that the particular patient poses to you as a doctor, or even other patients within that particular facility. This only happens in the event that persuasion fails, and that's when you can then create a departure from patient confidentiality in where the practicable options available to the practitioner has been avoided by the patient. So that confidentiality then, as much as it is a moral duty of the practitioner, it is also a professional value that must be inculcated in ourselves. And its breach is actionable. You can be sued for that. But the doctrine of reasonableness that I was talking about, especially when in your own evaluation, the patient or the person who refuses diagnosis, you see, or even the person who refuses to undergo test, he poses a danger to you as as a practitioner, and you are required at least maybe to keep healthy, going by the statistics that we receive nowadays, so that the government and any hospital would want to keep its foot soldiers, and in this case the doctors, the nurses, and the healthcare providers, as safe and as healthy as possible, as in preparation for a rainy day. So if in preparation for a rainy day, there is a threat to that particular preparedness for a rainy day, then in that particular instance, then you may elect then to, it's a reasonable instance for now the doctor to invoke or to breach this particular confidentiality issues. Allow me to stop there, and maybe as and when questions are asked touching on legal issues, then I'll be coming back to address them.
Thank you, Akili. I think you have done some good on shedding the light. You can go through some of the charts and see what applies to you to later respond to. But I'm seeing some questions about wearing of the masks, and whether if patients refuse to wear a mask, then the healthcare provider should not provide the care. So just to mention that ethical behavior is characterized by honesty, fairness, and equity, and just allowing what is the respect and dignity to be there. So I think we would ask ourselves, when somebody comes very sick, let's say they don't have a mask, I think the right thing to do is to ensure that they get the mask, but they need treatment. And how do you have somebody get this information? Maybe they have not read the billboards, or it may have fallen. So it gives the healthcare provider, ensure the healthcare provider will give the patient enough information to do the correct thing, and if possible, be part of that solution. So there are things being asked here about masks, about the tests. What if the test requires a cost for which this patient may not be able to provide, to pay for? So where does this throw us to? Because I know at KNH we are doing the tests to our patients because we know, first of all, it will protect the institution, it will protect the patients from even other patients, and the healthcare providers too. So we are interested. But I think the question is coming from the background of, what if this, I'm supposed to do the test and I don't have the money for it? So maybe Wakili, you could comment, you'll comment about that, and then we will have Dr. Juanita also weigh in a little on that, because she sees it happening on the practical side. Another question is about the matters of having the patients being discharged home when they are still positive for COVID. And Wakili, I would want you to discuss about something to do with an ethical principle called health maximization and efficiency. You've mentioned it a bit in a different language in your statements, which was very good, that the idea is whatever we have, would want to use it to the maximum. We have this bed capacity. That is why initially, at the time before we started containing the community spread, we were admitting all positive cases. But it came to a point, this resource that we have called hospital beds had a certain finite level. And so how do we maximize? So there was the direction of discharge at day 10. And it happens that it's possible for some people at day 10 to still remain positive. So there are no like direct answers, but I think you will emphasize that a bit, because that is where the government finds itself at. They have resources, but the ethical principle is you have to have health maximization from the resources you have, and efficient use of those resources, at the same time assuring that there is no harm, non-maleficence. Thank you. So we can start either with Wakili or then Juanita to mention something.
Okay, hopefully you can hear me. I guess I'll start. If you're talking about the masks, whether it's unethical to give service based on someone wearing a mask or not, one of the things that I've actually found on the ground is that if you actually talk to them, some of them get uncomfortable and put on their mask. Some of them actually just want a new surgical mask, but the ones who completely refuse, you also have to protect yourself. So it's not about it being unethical, it's about it being practical, because you have to practically prevent the spread of this disease. If you get sick, then you cannot attend to the many patients that you're going to attend to based on having to treat somebody who's knowingly exposing you to a disease. So it's one of those things where the Hippocratic Oath comes in, where you have to protect yourself first. A refusal of patients to put on masks in the right way of the hospital, I find that most people just find it hot. They don't like to wear it because they can't breathe. Apparently, that's usually the statement. I can't breathe properly with this mask. But when you tell them you need to cover your nose and your mouth because that's how you're going to get infected, I found a majority of them actually put on their masks well. I don't know if there's any other legal ramifications with this. So Mr. Fleming, maybe you can weigh in on the masks.
Okay. Now, first and foremost, withholding or refusing treatment because someone is not putting on a mask, in my understanding, it should and it is unethical. As a practitioner, my question would be, why is this particular individual not having a mask? Is it a question of blunt refusal, but there is availability of the mask? Or is it a question of not being able to afford the mask? So that before you withhold or before you purport to withhold treatment, then it's important to go to go to the underlying issues why the individual is not donning the mask. Then secondly, on the issue of exposing yourself, the practitioner, when you're attending to these patients or who walk into your clinic, you should be donning this particular protective equipment or paraphernalia like the masks themselves, so that you eliminate any infection or possible areas of infection that may expose you by an individual not taking these particular precautionary measures of putting on masks. So to me, allow me to bluntly put it that you are not allowed to withhold treatment or the necessary treatment because an individual is not putting on mask. It is important to go further than that to look at what is the reason behind it, just like Dr. Juanita has explained.
Thank you, Wakili. I think you had duly mentioned on matters of health maximization. There is a comment there about the child. We've mentioned of a child with a hematology case whereby we need to cancel the mother first and then we proceed to do the test. Of course, the child has a right to care, and being a minor, then the state is responsible to ensuring that the child's right is not infringed upon. So here, the question that comes, or what the hematology group had, is that leukemia is a treatment that will take a while, and we will need the mother on our side. So this is not the time for us to force her, but to engage. And so in this case, they engaged the mother, came with the relatives, and had a discussion so that they're able to infer or to give health literacy so that the mother is able to now make an informed decision. But remember, when rubber meets the road, Wakili tells us that the child's right supersede what the mother's values for deciding to withdraw the child to care. So to continue with the stories that the child the mother finally settled, accepted that, yeah, treatment, diagnostic process will continue. And I think the team is happy because they know that a child will do well with the mother being with them in the institution, in the hospital, other than saying, then you go home and live for us to continue taking care of the child, because this is long-term care. It will need cooperation from various levels, both during their stay in the hospital and in their stay at home, because at one point they will go home and they will need to continue being adhering to what they were told in terms of treatment and nutrition and even the emotional support that this child requires. So the dilemma is that this mother cannot be wished away just simply because she is opposing the treatment at that time. We need the mother to come to our side. So as healthcare providers, we ensure that they are well informed, we can win together, so that we do not take it to court and remain with the child and she says, I will come back when I decide to. And that has happened many times in this institution, and we have learned it is better when the parents are with us. But in case the child is at risk, then we'll go ahead and just give the care. If it is emergency care, we don't have that much leg space to make such a decision. We'll give the care and have the discussion much later. There are comments about the rights for the healthcare provider in the view of the pandemic, which have already been addressed. So I think we will go to these other comments about that if we cannot force a patient to the hospital, and so we cannot force also the patient to take the test. We will not, as an institution, we will not be able to really identify everything that is happening out in the community. But let's say the ones who come, of course, in the community also for public good, would want all those who are identified as contacts to be able to come for a test. But in the event they get to the institution, most likely they're coming with a symptom or two. And so by them being within the institution, then they will be able to be an added risk if we don't do anything about them. So there is the whole community approach that should happen in public health from the community. But then there's what we should do within the institution and what is the right thing and how to do it. We're learning that just having a conversation so that people know the risk they're putting themselves in is important. But in the event that can't work, then that is when we use the acts to enforce this and the other. Fleming, there is a question for you from Emily Rogan. I hope you can read it and respond to it.
I can't get hold of the question.
Yeah, she's mentioning.
Oh, okay, I can see it. Allow me to quote it verbatim. I joined in late and may have missed some of the following. Kindly outline the principle of common good versus ethics in public administration in COVID-19, particularly looking at China and the GOK. What recourse do we as Kenyans have in dealing with those who may have intentionally or ignorantly put Kenya at risk? How can the law be strengthened to stop future misdemeanors? Outline the current Public Health Act, what the current Public Health Act allows for medics to breach confidentiality in highly infectious diseases. Allow me to start by the issue addressing the question of confidentiality. During my introductory remark, I guess maybe you are not there. For example, in our situation right now where the virus is spreading so fast, it is worth including a word of reassurance for the practitioners. I know you may be wondering whether, and rightly so, whether in this particular case, you should share the knowledge or any reasonable suspicion that you have that a patient might present a danger of infection to yourself or the public, especially when you have outlined all the necessary ways of combating it through distancing, shielding, yourself or even the public from it has not been taken up by the patient in itself. You are wondering whether you can divulge that particular information. I mentioned earlier that the general rule is that it is legally permissible for you as a practitioner to share information. And remember, the objective here of sharing information is to reduce or eliminate that particular danger. Remember, I also mentioned an issue to do with reasonableness. And the reasonableness here comes in when you look at all the electives that you have. Has persuasion failed? Has your attempt perhaps maybe to convince the patient to adopt all the precautionary measures to protect himself and the public, has it failed? Then it is reasonable then that a departure from patient confidentiality may be practicable, and it can be achieved if, and it is available to you if the patient has failed to adhere to the precautionary measures you have outlined as a practitioner willfully and with wanton abandon, so that you remember your duty of confidentiality is to the patient. But again, it does not remove your duty to protect the public, especially in such pandemic. Also remember, during the introductory stages, I did indicate that the public health law that we have now really grants the state a fairly broad powers. And it imposes duty and legal powers on the state to assure everyone, including the patient herself or himself, that he is in a healthy environment, or the state is trying everything possible to avert the crisis that is looming. And for that reason, you can limit the patient's autonomy, patient's privacy, and patient liberty, which may be then available for, to you to invoke, to breach or to elect to divulge such kind of information. Then the second question, the other issue that you had is what recourse do we as Kenyans have in dealing with those who have intentionally or ignorantly put Kenya at risk? To me, this question is a very broad. There are so many people who've put Kenya at risk in various ways. One that I saw in the daily newspaper, for instance, there was a feature that there is an individual who received or who got all the clearing documents and walked into the JKIA to clear the PPEs, for instance, the donation from Jack Ma. The intention was to clear the consignment and perhaps maybe sell and realize the proceeds. Now, there are laws and regulation of dealing with such kind of imposters who perhaps would take advantage of this pandemic to make a kill. And they can be prosecuted, they can be put to jail if found culpable. And you have seen instances where people who've been indicted for corruption and processed through the justice system, and the kind of fines and jail terms that have been imposed. I think that is really a good step in terms of sending a strong message that, you know, you cannot walk in and out while breaching every legal provision and taking advantage of the situation while putting other Kenyans at risk. Remember, when PPEs are not there, you are at risk. When PPEs are not there, Kenyans who are seeking services are also at risk. To stem such, we need to audit our systems, administrative systems. We need to audit our justice systems in terms of trying to address such particular loopholes. And imposing such stringent measures would send a strong warning to people who would permeate the systems through their illegalities. Then they outline the principle of common good versus ethics in public administration in COVID-19. The common good for me would be the common good would be like you are looking at the ultimate good or the ultimate benefit that the society that accrues to the society vis-a-vis that of an individual. And it also may present itself in several ways. Now, is it the common good for the government to limit public movement during such particular pandemics? Yes, it is a common good. And limiting the movement in itself, limiting that particular liberty, so that in addressing this particular issue, especially in light of the public health good, and in light of whatever I had mentioned earlier, you have these particular sweeping powers to the state that in the event of such a pandemic, you can invoke such particular measures to stem the movement. And that's why we have the curfew, that's why we have self-isolation or forced quarantine in the event that all the attempts to persuade you to self-isolate or to self-quarantine or to self-test is not adhered to. So the common good would outweigh so many other things in the event that we have a pandemic. And the fallback position still comes back to the doctrine of reasonableness. Is it reasonable for the government to invoke common good to limit your liberty, to limit your movement, to limit your autonomy, or to limit that particular right of yours to determine or to elect that I am going for this test or not? Like for instance, when you now present, you walk into accident and emergency with all COVID-19 symptoms, but then now you refuse to undergo a common COVID test, for example. But then you are not that particular candidate who fits the bill to go and self-isolate at home. Can the doctor then just prescribe that, you know what, we are just going to wheel you into a ward of 8 or 4 or 8 or 16 patients? Because when they wheel you there, you are going to expose these particular individuals to the COVID-19 exposure, things like that. So for the common good, the doctors, it is reasonable then for the doctors to take this particular test even without your authority, because you are a risk to yourself, you are a risk to the doctor and the healthcare givers, you are a risk to other particular people who are also using that particular facility. So really, there is an interplay between a common good and the ethical considerations. But what is more better is to prevent and to diagnose you so that they really know that if indeed you do not have COVID-19, then let us focus on other particular conditions that you may be suffering from, which may not necessarily expose others to the disease or the pandemic that we are fighting. So yes, common good would outweigh any ethical consideration, especially some of the ethical consideration, like for example, refusal to get tested. But this would ultimately come after and every a tool that is available to the doctor fails. Like for example, persuasion. Like for example, being told why it is very good or the benefits of you getting tested for COVID-19. So that some of the people normally refuse. Like for example, I went for COVID test some time back, and the information that I was getting outside there, that, you know, when you present yourself for COVID test, it's like those people are digging your nostrils. The process is so painful. So many people fear the COVID test, not because of lack of information or because of experiences that others have been exposed to, but not necessarily the experiences that they themselves have been exposed to. So some of those particular nuances can be taken away by persuasion and by taking these particular people through step-by-step procedures in terms of testing. I hope I did cover most of the question, but in any case,
Yes,
I
thank
forgot.
you, Wakili.
Then I'll come back to it.
Yes, so thank you, Wakili, for that having been put very well. Professor Omwanzala wants to comment something, and as he comments, I'd want him to address the issue of the patients being discharged on day 10, and then also those who remain with positive results even after 3 weeks. For example, they are on home-based care, but the results continue being positive. So what advice are we giving to the institutions? Because we would be very wary of them coming back to rejoin with still a positive, a COVID positive test. And also comment about the sensitivity and specificity of the tests. Are they any different? Are we looking at active virus or just particles of an event that occurred a while ago? And so we don't need to worry. So Prof. Anzala, you're welcome. I hope you've been unmuted.
Yeah, thank you so much for bringing me in. Before I go to the issue of specificity and sensitivity, I'd just like to throw in something, and I'd like to hear what Lumumba will say. Lumumba, assuming tomorrow morning 30 healthcare workers at KNH present letters to you and tell you that they have considered the opinion that it is very risky to continue working at KNH. There's a very high likelihood of them getting infected with COVID. They want to take a leave of absence from work until COVID is over or until a vaccine is found. What will be your position on this?
A tricky question it is. Now, during COVID-19, we have had this directive from the government, executive directive from the office of the president, recalling everybody who is on leave to come back to duty to help in terms of combating the COVID-19. Now, whereas it is important that patients, that healthcare workers take leave of absence from duty, it must be taken within the confines of the law itself. And at some point, like now, we may, or the employer may be forced to decline the particular request to take leave of absence. And going back again now, my fallback position is the reasonableness and the public good, the common good for the public, for the healthcare workers to be out there in terms of to help the government and the hospitals in combating this pandemic. So yes, it is the right of the health worker to go on leave, but yes, that particular leave may be cancelled, or you may be recalled from leave to come and help address issues such as this particular pandemic. So that is not out of the ordinary. And the employer again is entitled to refuse that particular request in a justifiable manner.
Okay, now to go back to the issue of the RT-PCR test we are actually using. Yeah, it has caused us a lot of pain and a lot of issues. But what we know is that in terms of sensitivity, regardless of which particular primers or probes somebody decides to use, the sensitivity is such that we can pick one viral particle per mil. We can actually be able to pick one viral particle per mil, meaning that the test is highly, highly sensitive. And that's why molecular tests are that sensitive. But what causes problems is usually now the specificity. how specific are your, how specific probes, and the targets have you targeted in terms of saying that positive or this is negative? Ideally, any molecular, as far as RT-PCR for SARS-CoV-2 and COVID is concerned, to have 3 targets. You need to have a screening, and then you need to have additional 2 very specific genes to SARS-CoV-2. So the screening gene will be for beta virus, that where coronavirus SARS-CoV-2 belongs, and the other will be very, very specific for SARS-CoV-2. So you want to say that for a positive test, you want to see that actually light up, and that's what I actually insist for. For us here at CAVI, we are doing assay for research, but we only declare that a sample is actually positive when the 3 are okay. Now, on the issue of discharge, on the issue of positivity, that has been actually a big dilemma. But we have been guided by looking at data synthesis from various studies that have been done from various countries. And when we synthesize that data, what that data has been telling us that after 14 days of infection, and if all goes well and the patient has recovered from any signs or symptoms, any positivity you see from nasopharyngeal and oropharyngeal swabs might actually be picking residual viral particles that are not viable. Residual viral particles that are not viable. And hence, that's the reason why we informed the decision makers, because it was also becoming fairly expensive to keep waiting for a 2 negative tests. And we have seen prior to this, we saw patients who are staying over 21 days, over 30 days, waiting for them to turn negative. So we have actually been informed by synthesis of data from various projects, various individuals in various places who have been following this closely, and they tell us very well that 10 to 14 days thereafter, once symptoms are gone, what you're seeing is actually just residual viral particles that are not viable. Ideally, what would have been ideal is for us if we have the capacity to actually culture this virus. But capacity for culture is there at Cambridge, but again, takes time. And hence, that's why we have made this decision. So it is in there. We are still reviewing data as more data comes through. We are also still trying to review our own patients to see whether really after 14 days, what we are just seeing is actually just residual viral particles that are not infectious. Thank you very much.
Thank you, Professor. Now we are guided because we've been having staff who continue testing positive. So, so do you advise us that it's okay for them to come back to work, or they can, because they've been in home quarantine, so it means they are not infectious anymore, but they just have a positive test?
Yes. Ideally, after 14 days, when there is totally all the signs and residual symptomatology is all gone, and the individuals are still testing positive. What we are also using, other than just saying residual, we could also use the cycle threshold, the CT value. Okay. Yeah, we could also use the CT value, and that CT value can also give us a sense of in terms of, it's not the right way of doing viral load, but it's a surrogate of a viral load, the CT value. So these are things we can use in terms of symptomatology, but also using at the CT value and we can then be able to make a decision that indeed, most likely what we are seeing is just the residual virus particles that are totally not viable. But in addition to that, the study we are now conducting at CAVI, we are looking at long term. We are looking at patients over a period of a year where we shall keep looking to see whether there's any rebound, whether this virus comes back, or whether there is any form of reinfection. Because COVID, as we know it, SARS-CoV-2 COVID is actually still a moving target, but we have been informed by synthesis of data to make this particular decision. So for me, really, depending on how the healthcare worker feels, I would actually advise that depending on how they feel, that maybe they wait a little bit till the test is negative for them to feel confident that the virus has actually gone away.
Okay.
That would actually be my position.
Thank you. Actually, that advises us because there is the common good both at home and then also in the institution and where just to place these patients. So now we are informed that they should not be too worried while at home, because remember they've been living in a separate room, being given food at the door, disinfecting all their utensils. So it means that after the negative test and they're on day 21, if it still remains positive, then they could ease that a bit, even if it's still positive. So I think we will go to a round of comments for closing remarks from our panelists, from what we have shared and the cases that were the cases that we shared here. So we'll start with you, Anita. You, Anita, could you give us some comments?
Ethical issues in the medical field are quite diverse, and there's never quite a black and white answer to any of these things. In the case that we are in now in a pandemic, information to the patients, to the publics, to your loved ones is key for them to actually understand what is happening. Actually takes away some of the fear and some of the stigma. So I just encourage everyone to spread the information on that we can actually hopefully manage this completely, but it's not something that will stop our lives. So when it comes to the ethics, being reasonable, common good, things that you would want to be done for you, your loved ones, and the people around you, we should think about those things. But this discussion will not end here. It will just keep going. Hopefully we come up with some really good solutions. Thanks.
Thank you very much, Anita. So one thing that the dilemmas in ethical dilemmas in practice bring to us is that there are no silver bullets. I mean, there's nothing that will just clear it all at a go. It is a matter of always engaging and remembering that the two opposite sides, whether you're talking about the patient's protection and the healthcare worker protection, each of them has a right and the other one has a duty. And even the healthcare worker still has a right. So meaning there are conversations that continue. And so Wakili, you've mentioned about the reasonable risk. And so I'm just thinking that, for example, I don't provide care and I need to account for why I didn't provide for this care. And so the institution will be made to confirm that there was some level of reasonable protection. And on the other side, I'm like, I was unable to provide care. I mean, so as we engage in this, it is true that the supplies will always be sufficient. At some point we are trying to strain, but the issue of reasonableness, I think, has been emphasized over and over again by Wakili, and I think all counties and countries have had this kind of strain as they handle the pandemic. I think as we draw towards the end, I think we will ask you to give us some comment in the regard of in the event that care is not provided, what difficulty will what will I need to answer as a healthcare provider? I'm not talking like I'm not one, I'm a healthcare provider myself, but there's just some reality that somebody comes for care and I have this level of protection and I am not sure. So what should cross my mind as I'm making my decisions? And in the event I'm asked questions in another setting, what will I use to justify so that I'm in a better place, so that I am prepared? Because there's a lot of stigma and fear with COVID. As Professor said, it is unfolding and there's knowledge that is coming that wasn't there. But as that happens at the same time, these are ethical issues. So Akili, could you give us your remarks?
Allow me to address the issue together with Dr. Raj's question. Just to state that as a practitioner, all you are looking at, allow me to divorce the duty a practitioner has to the patient and now look at the duty an employer or the managers to their staff or to yourselves in terms of providing the resources within the reasonable limit. And this particular resources includes the equipment, includes the staff, the optimum level that is required to address the issue of the pandemic. We are human beings, and there is a limit as to which a human being can go. So that in the event that anything happens, let me say that that makes a call or a misjudgment, then that particular call or misjudgment leads to a harm, then you cannot prevent an individual from suing you. However, in the event that you have been sued, you have to invoke the reasonableness doctrine in terms of looking at what is the ratio of perhaps maybe a nursing care, healthcare providers to the number of patients. Did we have the PPEs? Because you are also allowed to make those particular conscientious objection in the event that you feel really inadequately equipped by the person who is supposed to equip you in order to provide those particular individuals. So that the context of looking at your liability, if any, is not really from a far-fetched environment, but from the environment that has been provided by your employer. Do you have the PPEs? Do you have the drugs or the supplies that is adequate for you to address the patient needs? So you are not going to be adjudged out of out of an environment that is not within the particular hospital. All the adjudging happens within the context of the hospital and all the reasonable resources that have been provided. Then there is the other issue that nowadays we tend to look more at combating COVID and leaving the particular patients in deplorable condition without taking much care of what happens. It's like all the resources have been channeled towards the fight of the fight against this particular pandemic. There is also important reason why we need now to strike a balance, because what happens at the end of the day when we have depleted all our resources, yet we are also still staring at other particular pandemic. So we need going forward to do stock taking on the depth of our pockets, also the other health risks that we face other than COVID, so that we don't just look at COVID only without covering other areas that we may need to look at. That does not, the pandemic does not justify neglect of other particular patients who are seeking care. they must be aware that the hospitals are still operational and are also still offering other services other than the issue of COVID tests and managing COVID patients. But allow me just to conclude that the duty of the patient to the practitioner to the patient is key, as well as the duty of the employer to yourselves, because I know right now so many people are worried. The doctors, the nurses, and other healthcare providers are very worried. Really, do they really care for us, even as they expose us to this? These are vital questions. These are vital conversations that we need to have going forward without shying of any consequences or repercussion, because at the end of the day, we need you for a rainy day, which may come or may not come. Thank you.
Thank you very much, Dr. Wakili. You've mentioned the duty of the employer, and those are matters that cut across up to what we call organizational ethics, in that how do we prepare ourselves as an institution to respond to this without having suffering on both the side of the patient or the staff. We've had a lot of guidance from the Ministry of Health, but there are also details for which the institution comes up in terms of communication, and for the communication to be done in a manner that it does not raise anxiety within the staff, and just making us know what to do when this happens, like the HR, to ensure that in case our staff is infected or exposed, what happens? Is it very clear? And so I should mention that the hospital has put in measures and has put the standard operating procedures, and has tried to ensure that as an organization, in case staff is exposed and in case they're infected, they have the mental and psychological support, even as much as their physical support is assured. So that is also an important thing of ethics, that the employer has a duty to the staff. And so I think we are on a learning curve, but I would say that we are doing fairly well in terms of ensuring that people know what they need to do. But every other time we discover it needs to be continued. So we will continue ensuring that we are informed, and that staff don't incur moral distress by the work that they do. And in case they need a debrief or just a time off, then their frontline managers, those with them, are able to recommend what is required in the time of a pandemic, because this is unusual times that requires also unusual measures to be taken. I think we are about to come to the end. I think I will would want to ask that you forgive us for not allowing you to raise questions so that we're able to manage this, but we're able to pick most of the chats, and they have been well addressed. We thank Wakili for being here, and thank you, Dr. Juanita, for the practical example, and for the KNH Hospital Ethics Committee led by Dr. Wambugu for enabling us to put this together, and the head of patient affairs, that is Anne Kirema, just ensuring that this was organized and prepared. So I'll hand this back to Dr. Karingo to conclude. Thank you very much.
Indeed, this has been a very interactive session and very informative in matters to do with ethics during this time and the legal perspectives. And we really thank you, our participants, for being active participants and raising your questions, and from the comments that you are getting. We appreciate that. We have come to the end of today's session, and you are welcome to join us tomorrow, whereby at from 10 a.m. to 12 p.m. we'll be looking at experiences in managing COVID-19 disease. For any of the queries that may have not been answered during this particular session, we'll continue having other sessions, and to particular issues such as the treatment. Others have raised questions in regards to treatment, in regards to management, home-based care. Those ones will be answered in other sessions, and not particularly this one. And so we thank you. Have a lovely evening. Thank you.